And then Take it, yeah, no problem. Done one in person for a while. Ooh, many people to ask questions, potential victims. So sorry about the delay. It took the computer hates me and it took about 20 minutes to load. And then anyway, everyone on Zoom, I'm assuming that it's actually working and people can hear. Thumbs up, I guess. And everybody can, you can see the screen.
Thumbs up.
Thank you, Lisa. So, so this is one of multiple introductions to circadian rhythm sleep-wake disorders. So, over the years, we have realized that this is a pretty complex topic. So we are introducing it in little bits, coming back and revisiting. So some of this you may know, but kind of hearing it in a different way or a different perspective. But really, we do want to have at least 4 to 5 touch points throughout the year, because we've also found that it really helps when you guys are both managing your patients, but also for the boards and the right exams. So, getting it all dumped into like 1 to 2 lectures wasn't necessarily the best way to do this. Okay, so going to talk a little bit about, what is a circadian rhythm. Briefly touching on some neuroanatomy. This will also, I'll try to pepper these questions throughout the rest of the year, because you will sadly have these also on the boards, more likely to be, studied right before and then soon forgotten. Diagnosis and then again, treatment, but remembering at least 4 to 5 talks over the next couple of months on that. Okay, so, what did I call it?
I'll give you a little more. Hide it. Floating.
And give me another gray box there to there. Okay, so so a couple different things so that we get our vernacular, our verbiage together. So we have to consider what we're talking about. What is our biologic rhythm, or what is our endogenous? What is our internal rhythm? So that is where we're not actually getting input from the environment. So that's like thinking living in a cave, which actually they did. If you guys want to go down to Kentucky to Mammoth Caves, they did some things. They trapped people in there. Part of that was also, I believe, treating tuberculosis, that they thought the cave environment was. But there's some interesting stories of, like people having less than happy lives while they were stuck in the cave. Zeitgebers are these inputs, which I'm gonna talk a little bit more, and then we have into our circadian rhythm. And entrainment is when our environment and our circadian rhythm are working well together. So that might be, you're never going to ask your patient, have you ever been entrained? But like, have you been able to get to work, at time and go to sleep at the time that you want to? That suggests entrainment. And then tau is the term for kind of what is your biologic 24-hour day, right? We do know that tau changes across the lifespan, and it can be different for people, and that is a large part of what happens with these circadian rhythm sleep-wake disorders. Okay, so, and then definitely you guys have had this talked about before. So, and we can sometimes use the term like sleep drive. It's a good thing to say that with patients, but keep in your mind kind of the full science of it, the homeostatic sleep drive. So basically, the longer you are awake, your greater drive to sleep, and then that interacts with your circadian rhythm. Okay, so this is the image that you see all the time, and I hate this image. I don't know, it's not really intuitive to me, but every single talk you go to that talks about the 2 processes, this is kind of what they're going to show you. But basically, here is your homeostatic sleep drive, and here's your circadian rhythm, which is flexing. Okay, so a long, long time ago, I made this. And now that we have AI and everything else, that I realize that this is just a very sad one, but but at least kind of to me makes a little bit more sense. Okay, and so keep in mind that this, your circadian rhythm is an activated rhythm. So you're going to be thinking of that as waking you up more. So across the day, so it, increases, but then you have your dip. So this is that siesta. This is like people get sleepy after lunch, or if they're in a boring, meeting, but it's a little hard to fall asleep when I can look at all. But this is a time where it is a little more sleep conductive. And that's because we've just had a little bit of a dip in the alerting signal of our circadian rhythm. Okay, then you get a little bit more alert. At the same time, we still have an increase in our homeostatic sleep drive. But then when your circadian rhythm alertness signal goes down, then that's where, hopefully the magic is happening. And you have both the homeostatic sleep drive and the decreased alerting signal from your circadian rhythm. And then you go 99. Okay. But when we talk about circadian rhythm, a lot of times we think about melatonin and we think about sleep, but it's way more than that. Okay. And also keep in mind, we have our core body temperature, we have alertness, we have hormones, we have eating, we have blood pressure, we have clock genes, we have lipids, we have bowel movements, best coordinate. Where's the bowel movement? It's actually like 8 o'clock in the morning.
8:30.
I see what's going on. Yeah, oh, sorry. Yeah, going along, you've had your morning coffee, which goes along with that at the same time. So yeah, so keep about, it's much more than just our sleep-wake cycles. Okay. So here we have, our friend, the suprachiasmatic nucleus, which you guys will absolutely get that on your board question, but you will know that. But do keep, it is also, you do need to know to the level of the anterior hypothalamus, right? Okay. You have two components. We have the core and the shell, and I've not really heard them, or I don't recall any questions to that level. But just keeping in mind if you have it, the core is doing the vasoactive intestinal polypeptide and then the arginine vasopressin. So SCN, anterior hypothalamus. Okay, so the functions of the suprachiasmatic nucleus is threefold: sleep-wake cycles, the endocrine rhythms, and molecular rhythms with the clock genes, which I'm not really going to be talking about today. You guys will get that. Here are some of the neurotransmitters that we see. I will just let you go ahead and read that. I think I hear a little bit more about definitely GABA, but also somatostatin. But just at least have some familiarity of saying those. So why do we need a circadian rhythm? And so the main thing is that we need to link to our environment. Sunlight's changing, temperatures are changing. If you think about animals, it can be part of like how you go into the breathing system and uterus and other things to that. And then the other big part of it is that, we don't have this exact 24-hour clock. So we have to get these inputs to kind of keep us at least somewhat connected. As in why you guys are all going to feel really sleepy and cruddy in like November, January, and February, but you see very little of your Zeitgeber of the sun, and you will feel much more sleepy because of this kind of connection to the environment. Okay, so the main Zeitgeber that we have is actually light, which we have, kind of alluded to, but we have other things too. So, we have some what can be social considered, so eating with that. And then temperature. But so the biggest one is actually going to be light. Okay, so going back to the icky neuroanatomy. So what we have is light goes into the retinal ganglion cells with melanopsin, which is pretty easy. Melanopsin, melatonin. You're going to be able to recognize that on the test. And then it goes through the optic nerve, and within that optic nerve, it's going to be to the retinal hypothalamic tract, and then into the SCN, okay? So the retinal ganglion cells are different than rods and cones. It's a much, much smaller percentage, maybe about 10% of the cells, right? So somebody could be blind, but have intact retinal ganglion cells. Okay, so that may be more likely to have if you have somebody with maybe like, you know, severe damage. In like the cornea or something else like that. And sometimes so people can have blindness to the point where they don't have light perception, but still have intact retinal ganglion cells. So many people who might be blind could still have this intact, but you definitely get concerned if you have somebody who is blind. Okay. But you can also have, you know, damage in here that can cause it. Okay. So here is where we kind of have the two different points. So that was kind of the simplification. But what happens is once we get to the SCN, we have input into the dorsal medial hypothalamus so that you can see that. And here, this is a little bit of that powerhouse where you're going to see here where it affects the endocrine system, here where it's affecting more of the sleep system. Okay, so just briefly with the endocrine system, which I'll talk a little bit more in another slide. So the dorsal medial hypothalamus going to the paraventricular, and then that is where we get the input from the various circadian and the endocrine systems. Okay, here for the dorsal medial hypothalamus, it's going to go to the ventral optic nucleus. So when you guys have, I mean, you've had like one or two sort of neuroanatomy talks at this point. Yes, Dove?
No.
Okay. So I can send you the slide and then when we can kind of go into that a little bit more. And there is an older paper that has a really kind of a good summary of it. I will be honest, most of us will kind of read as like neurobiology for the sleep physicians that had that two reading. Most of us will look at that and kind of memorize it before when we need to, and then kind of they sort of remember. Most of us aren't like rock solid, myself included. But you know, so but you will be reading quite a bit or hearing a little more about the ventral level preoptic nucleus and here going to lateral hypothalamus, which you guys know again is orexin and hypocretin. So that is the outputs. So that's where everything is going for the SCN. Look at the clinical here in a bit, you guys. And then here is the inputs to the SCN. Okay. And then once you guys have had a little more neuroanatomy or something, you know, these systems will start to make a little bit more sense to you. Okay. So from the midbrain, you're going to have the serotonin. Okay. It's going to be a negative input. And then for like acetylcholine, so you have the forebrain and the cholinergic system going in. And then a lot of times, you know, most everything that we have here is a negative input. Okay. The only positive is glutamate. That's an excitatory input. So these are a couple of the mnemonics that I have used that helped me. And I also really want you guys to know how hard it is to find, you know, a picture of glutes that is not going to get me fired. Then maybe I may help you remember it. Okay. So the eyes, because we're going there, you know, circadian, SCN going in. So glutes are exciting. So glute is excitatory. And it will, I promise you guys, that is a board question. Because I'll give you a list of what's excitatory, what's input. Okay. And this is not, I mean, I remember from neurology, this is how, or I don't know, just RNS, they're next to each other in the alphabet. So serotonin, the Ralphie nuclei. That's RNS. Okay. I have no good mnemonic for that one. Okay. Okay, so we haven't actually talked about melatonin. So the function of melatonin is really to help kind of connect for this. And when we talk, you guys have heard about dim light melatonin onset. So DILMO is typically 2 hours before sleep onset. It is made through tryptophan, many steps. And talk about that a little bit. So the way that melatonin actually goes is SCN through the spinal cord to the pineal gland, and then you get melatonin. You know, they talk about it as the dark hormone. So again, so that is kind of the broad overview, but here's a little bit more of that sort of complicated. So here you have, you know, input in the eye going to the SCN, and here is where we're going to the pineal gland and secretion of melatonin. But this is also when I talked to you guys about the endocrine part of it. So here you have the eye, right on the going into the SCN to PBH, and then to the pituitary, so TSH, ACTH, cortisol. So a little bit of that linking. But this is actually kind of interesting, and I haven't really heard a ton of information about it, but a large part of melatonin actually can come down here where we have paraventricular hypothalamus up to the superior cervical ganglion, then up to the pineal gland. So there have been a few case reports of people with a severe cervical injury where they don't have melatonin secretion. Okay. I think it's also, I mean, we had a talk a few years ago about sleep disorders and patients with spinal cord injuries, and they often have really disordered sleep. But of course, it's multifactorial, right? There's pain, there's, you know, the emotional components, all of that. But like, here's another one: absence of detectable melatonin, but preservation of cortisol and thyroid rhythm. So again, showing melatonin, but then not. Okay, so here is a question. One of you guys want to read it and then tell me.
65-year-old left-hand dominant woman is brought into the clinic by her daughter, who states that her mother has been falling and staying asleep at night. Patient has a history of Alzheimer's disease diagnosed 5 years ago. She was at a nursing facility and stays indoors most of the day. The disease can cause retina and optic nerve lesions and project to a hypothalamic nucleus, causing this patient's sleep disorder. This nucleus is anatomically situated in which region of the hypothalamus? So, suprachiasmatic nucleus.
I would think anterior.
Anterior. All right, we'll go with anterior.
Okay, you guys, anterior rocks. Yes, it is the anterior hypothalamus. So if we can get some mnemonic, can we put SCN and ants? Can you think of little ants in them? Is that SCN? Ants. Anterior? I'm sorry, I need mnemonics.
Yeah,
You know,
mnemonics
I
too.
like, yeah, like. Okay. So here's just a teaching point. So, you know, Alzheimer's disease, we know that there can be visual input changes, which may affect the SCN. Which, you know, we definitely know with people with dementia can have their sleep affected. But most of you just want that question. Okay, so and going back to things that are making life a little bit easier to remember. So with melatonin, think of two. Okay, so there's the 2 points of this is dim light melatonin onset 2 hours before sleep. And the offset of melatonin is where you go from the core body temperature to typically where you wake up. And the nice part of that is it's also 2 hours. So you can be, you know, memorize 4 or 5 hours, but I like 2 or 2. That's only one thing that I need to remember. Okay, we don't really have any way to measure melatonin. So typically, when you're trying to figure out someone's circadian rhythm, you're having to just go by their sleep wake patterns and take a guess. And that's why we need this kind of fundamental structure of knowing these times. You can measure it in the saliva, urine, and serum, but to actually, and even research studies are hard to do because you might have to do a sample of like every 30 minutes for like 3 to 4 hours. And then every time you're actually measuring it, it's like $20. So That's why these studies are hard and why it's also not a clinical measurement, okay? So, you're gonna see, the other thing we have is the nadir of the core body temperature, okay? So when the nadir of your core body temperature, when it's lowest, that is, when your melatonin is highest. On it, when your melatonin is highest at 2 hours before. Just want to show this image. Okay, so here. So here's your DILMO. Here, your melatonin is at its peak. And then here is the lowest, the nadir of your core body temperature, okay? But this is also think about it for you guys when you have been on call or the techs are calling you or you've been in the hospital, right? So when your core body temperature is low, your subjective sleepiness is at its highest, your performance is worse. And I really don't know why triglycerides, but it was in the picture, it's not what I'm doing. So, just think about that at call. So for many of you who may go to bed at 10 or 11 and wake up at 6 or 7, this is 4 o'clock in the morning. So you just have a general idea of like if someone wakes you up at 4 to 5, how you feel. Like, you know, like right on, sharp, ready to get questions by Dr. Hirschner, all of those things. Skip this. Okay, so I'm gonna do this really quickly. I don't want to run out of time. So an 18-year-old girl presents with 1 month history of headaches and chronic fatigue since starting college. She has a rigorous schedule. She reports getting less than 4 hours of sleep each night and wakes up early each morning to study and prepare for classes. She denies difficulty initiating or staying asleep or illicit drug use. Everything else is good. What disorder does she have? And by the way, I really don't like this question, but I think there's some points that we have discussion, hence why it is in the top. So jet lag, insomnia, irregular sleep-wake rhythm disorder, or shift work disorder.
Yes. Because aren't teenagers normally more delayed?
It's still right? So
Yeah.
like a
You're
regular,
waking-
that's kind of like throwing me off, right? Cause a
Yeah.
regular sounds like a regular.
So yeah, I don't, and so I don't really like this question, so let's
Really
talk
any
about it.
answer.
So
Yeah.
I agree. So do you think this patient has jet lag? No. Does she have insomnia?
No.
And we know that because she doesn't have a hard time falling asleep or staying asleep. Irregular sleep-wake rhythm disorder, I will talk about that, but that requires somebody to have 3 sleep periods in it. She doesn't have. So then what's the other option? Yeah, so basically, she's getting up early to do her classes, and so she's not allowing herself enough time. So shift work is probably the closest one. But it's just a little different because it's, you know, school, not her job. But so this is in here just more for the discussion, not because I love the question. But it was a seed bank from AS, so whoever let that one through was bad. Okay, so you're gonna get lots of people who will talk to you about melatonin and they're taking it. It is much better at impacting the circadian rhythm than it is as a hypnotic. Here's a study where it basically showed, you know, taking melatonin, that it had a 2% increase in sleep efficiency, and that was really interesting. So it really, when people say melatonin is not really working, it doesn't as a hypnotic. Okay, so here are our circadian rhythm sleep-wake disorders. We have delayed sleep-wake phase disorder, irregular sleep-wake type, jet lag, advanced non-24 hour and shift work. I'm not going to talk very much about jet lag. I will say for the boards, and I think for the right, there are actually a fair number of questions on it, which seems not fabulous because most of us don't manage jet lag. That's not the patient that we're seeing that comes with us, but just be prepared. Okay, so, remember, intrinsically, for many of these disorders, it's not so much the circadian rhythm that's the problem. It's the mismatch between what you need to do and your rhythm, okay? So when you're talking to a patient, how do you start to have an idea of what their endogenous rhythm is? Because you're not going to have their melatonin and they're unlikely to let you put in a rectal probe so that you know when their native like core body temperature is.
So you can ask about like on days off, like what do they do? And like if they have like a long period of not working or like no commitments, like what they
Yeah.
do.
Yeah,
How they
exactly. So like, you're basically trying to get an idea of like, when you don't have commitments, what do you do? Okay, and that can be hard because sometimes people may not have a period where they don't have commitments, but if you can get like, okay, you're on vacation for 2 weeks, what were your sleep patterns? Okay. And, other things that you can start to ask kind of is like, when do you feel the most sleepy? When do you feel most alert? Those kind of things. And it is, especially when you have a circadian rhythm, it's actually very helpful to kind of get more concrete information on what they do. Like what is their shift? Like, okay, so you're a nurse, you have to be here at 7, but you have to get up at 4 o'clock in the morning because you have parking is awful and you have a commute, right? With my college students, I can get this, I honestly have to get a sleep schedule that usually covers Monday, Wednesday, Tuesday, Thursday, and the weekends. Like, because they're gonna get up most people are gonna get up for the first obligation of the day, whether that's work, school, or kiddos. And fundamentally, if you're gonna distill a circadian rhythm sleep-wake disorder into kind of, this is a little bit of read my mind. What is the manifestations? There's 2 primary ones for circadian rhythm disorder. What 2 kind of simple fundamental things is your patient going to present with? Insomnia, and
Daytime sleepiness.
exactly, because it depends on where in that circadian rhythm they're gonna have that, right? So they can have insomnia because they can't fall asleep when they want to for delayed, but when they have to wake up for class, they're horribly sleepy. So a lot of times you're not gonna have both of those things in the same, when you see both of those things, have it kind of reflect in your brain that, oh, I might have a circadian disorder. So we talked about that. So AM, depending on it, it may be that really sleepiness with your college student. This might be your insomnia, and then it impacts your daytime function. So you can click on this is an actual real email. I have had this for a long time, as you can see. Dear Dr. Birchner, I'm a student at the University of, I don't know, and I have sleep disorders. I can't sleep before 4 in the morning, and things go worse when I am under stress situations. Right now it's 4 or 5 in the morning, so I don't know when I will fall asleep. Sometimes I go to bed at 10 a.m. in the morning and wake up at 7 in the afternoon. My roommates think I'm crazy. Nobody understands me. The purpose of this letter is not asking for medical advice, but offering my body to the science as an experiment subject. If at any moment, you need a person to be part of an experiment on your undersleep, please call me. Heck. Poor guy. Okay. So he has delayed sleep-wake phase disorder. He can't fall asleep until the early morning. If allowed to sleep long enough, he will sleep a normal duration and it impacts his daytime function. So, someone could be a night owl. Like, I have students who go to bed at 3 and then wake up at 11, but their first class is at 2. They're fine. And so their schedule changes. Oh, it didn't work. That's cute. Okay, so, prevalence, depending upon the age of the person, may be upwards of 15%. And there has been some reports of association with this clock gene. Key parts of it is that you're gonna have oversleeping when they get the opportunity, which typically will be weekends. But there is other things like again, most of this is gonna be young adults, adolescents. There is higher reports of depression, anxiety, school employment problems. So, intrinsically, it's probably best not to be a night owl, but so just keep that in mind. And then the other thing I want is, so when people when fellows present to me, I often hear people will say, oh, there's mind racing. Okay, so two things I want you guys to think about. So when you have someone with delayed sleep-wake phase disorder, they know they need to go to sleep, so they go to bed, they can't fall asleep. An awake brain thinks. Doesn't always mean that it's a racing thought, right? But they're not sleepy, and so the brain is gonna think about things. And the other part is many of these patients will develop psychophysiologic insomnia symptoms because as soon as they realize that there's consequences to their sleep schedule, then they're gonna start to get anxious and frustrated and worried about it. So at any point in time, you can have both of these factors playing a role in it. So a couple different things. Delayed sleep-wake phase disorder happens because you have a liver dim light melatonin onset, right? Why do these people feel so terrible in the morning? So one is they may not have had enough sleep, but there's another component. So they go to bed at 3 and they wake up at 7 or 8. So they've had 5 hours of sleep, so they're tired from that, but they even feel worse.
Melatonin speaking.
Melatonin speaking, and that is melatonin's the highest, which does what to your core body temperature?
Lowest.
Yeah, so that might literally be, if you want to rephrase it, so although it's 8 o'clock in the morning, it could be like you getting up at 4 a.m. And the reasons that people may become delayed in adolescence, we kind of how maybe longer at that point from a developmental standpoint. And there's some suggestion that night owls are actually more sensitive to the melatonin suppression that happens from light. So, you know, it's a double ring, right?
Do they have to present with insomnia? Because if you're like chronically sleep deprived, you know, you may be able to sleep.
So they're. So your question is basically if someone's homeostatic sleep drive gets high enough that they may be able to fall asleep. So what you typically will see is they will crash. Like, so then they'll have like 4 or 5 days of terrible sleep or they're getting very little sleep. And then one day they go to bed at 9 or 10 because they've had so many days of insufficient sleep. But then once their homeostatic sleep drive is kind of caught up, then that circadian rhythm causes the insomnia. Does that make sense?
Yeah.
Yeah, so that's what they'll, you know, usually say, like, yeah, I crash, you know,
It's like the sleep dead.
Yeah.
Like how long does that usually take? Or like, you know what I mean? Like, I guess, I don't know.
it has to, I mean, it would be all individual. I
Yeah.
mean, it really, very, very individual. So here's an example when we, you know, have a sleep log. Here you see, you know, when they get the chance, they sleep longer, so it's a little tax there. Here is taking a look at, you know, so here is, you know, 3:30 in the morning. When would you expect this person to be able to fall asleep? Probably. 5:30. Okay. And then again, here's that same example. They may be sitting in class. And I'll tell you guys, I was a rip-roaring night owl in college and I usually still went to classes, which why I'd be sitting there and I'd be taking notes and, you know, and fall asleep and with, you know, couldn't keep the words. But yeah, you know, you're probably not, you know, gonna have your best performance on a physics test if that's where your core body temperature is. Okay, so, you know, advanced sleep-wake phase disorder, we, you know, we think of our grandparents. And again, this is also this idea that your circadian rhythm does change your lifespan. So here they've, you know, increases with age. 1% of middle-aged or elderly. There is some period 2 and a couple case series showing an association with autism and maybe a shorter tau. So here you have your dim light melatonin onset here about, you know, 1:30. So when would they likely feel sleepy? So this is like incredibly advanced. I don't know where they got this person. Okay. And then, you know, so here you can see that they're going to bed 8 and then waking 4. So speaking of this, what might an advanced person present with? Again, we still have our, you know, sleepiness and insomnia, but what particularly might they be bothered by?
Daytime sleepiness, if it's like that previous guy, where
Sometimes. Early morning awakenings. So. Because they're not, you know, that they don't necessarily want to get up at 4 AM and they're not putting together that they're either, sometimes people can push through and go to bed at 9, but then they still like wake up at like, you know, 3:30 or 4. So that's just what it does. It certainly doesn't mean all early morning awakenings are advanced, but just kind of keep that in mind, and it sometimes needs to be teased out. So, you know, here's actigraphy, again, just kind of showing, you know, here we have the delayed and here we have. So this is also where the language gets a little bit confusing, because we have delayed and we have advanced, and then we have the circadian patterns with the disorders. So I still actually often have to think about it, right? So we have, if you have somebody with delayed sleep-wake phase disorder, you actually want to move them forward, so you're advancing them. And so that's where it can really start to kind of mess with your brain. And if you have somebody with advanced sleep-wake phase disorder, you want to delay their circadian. So you always kind of have to almost think of what direction you're trying to move circadian. Okay, so this is the way that I think about it. And in large part of this, because when you're seeing someone, the only real measurement that you have of their rhythm is what they tell you that they can successfully sleep at. And so this is where we get our native or core body temperature in the Dillman plan. Okay, so right now, what happens when you're using light and melatonin is related in large part to the nadir of the core body temperature. Okay, so if I put light on this side of the core body temperature, then it will advance their circadian. Okay. If I put it on this side, then it will delay it. Okay. And then the same thing that we have, we're going to have melatonin far away from the nadir of the core body temperature to also help delay it. But this is where light can be very hard, because if you go back to this college student, you have a college student that wakes up 9, a couple days a week, 11, and then on the weekends gets up at 2. When is their nadir of their core body temperature? I have no idea. So oftentimes you might be very conservative on your timing of light, because you don't really know that. Okay? Because if you mess up, you can make someone worse. With advanced, we are going to use, you know, light, and that will get kind of help, you know, delay that. So here's the image that I kind of, the simplification that you guys are gonna have. So you're going to, at the nadir of their core body, you're gonna have melatonin 4 to 5 hours before they successfully can fall asleep. And then you're gonna have light on the other side of the core body temperature, on the opposite. And then going back, how do I guess when their core body temperature is?
2 hours rise time.
Yeah. So it's like 2 and 2. Okay, so we say, you know, low dose, so 0.5 to like 1 milligrams. This was from something else at 5. But I say successful sleep. Sometimes people will say when the person wants to go to sleep. To me, that doesn't really work, because when someone's goal to sleep may have no relationship to what their biologic rhythm is, right? Like do you know what I'm saying? So I really try to pinpoint on what I know. So if somebody can go to sleep at, say, 3 AM, then it may be, you know, 10 or 11 that hour. Because they may have an unrealistic expectation or an unrealistic goal. So that's why I really try to work on what they have. Okay. Bright light, which has not been defined. 3,000 to 10,000 lux after the nadir of core body temperature, which we just talked about. Practically, this can be hard, right? If someone has a office job, maybe they can do it maybe by their computer. The students, sometimes I'll just say no glove, no sunglasses, no hat, because you're walking to class. That might be the only thing that they can do. Okay, and we can talk. There is some studies of showing kind of blue blocking glasses. A couple hours before bed can also help prevent suppression. Yeah, because melanopsin responds to that blue wavelength. Okay. This is where we use the homeostatic sleep drive. This may be more typically done in the pediatric. I have done it plenty of times in the past. I really don't do it so often anymore, just because it's hard for somebody to have like 7 to 10 days that they can really dedicate to an absolute wonky schedule. But what you're actually doing is you're using the homeostatic drive to force the circadian rhythm to adjust. Okay, so with that, do you guys have people go to bed earlier or later? What's that?
Later.
Yeah, so exactly right. And the reason that I'm bringing this up is, sometimes people will get literature that says like go to bed 15, 30 minutes earlier every day, but that is working not in conjunction with the homeostatic sleep drive. So if anything, it's actually going to cause worsening insomnia because there's going to be more time to bed. But here, so basically, you have somebody go to bed at 6 and the next day 9, and you literally rotate them around the clock. And then once they are at their goal time, then they have to be very, very rigorous with those behavior changes. And then the other part is, patients need to know they're going against their rhythm. So this is a challenge to maintain, right? Because your body is still going to be like, oh, I want to delay. And so the other thing I tell these patients is the biggest thing I want them to focus on is their wake up time. So I'll be like, okay, yeah, you mess up your schedule. That's fine. You don't fall asleep till 5 o'clock in the morning. You still have to get up at 8. I don't care that you've only had 3 hours of sleep. That's going to be your best thing. Just don't drive, right? So, advanced sleep-wake phase disorder, it's kind of, here is one ASM protocol that they talked about. So 2 hours of bright light. I have not had a lot of success with this. With bright lights, I've maybe been able to shift people later a little bit. But usually I personally haven't had a ton of success with it. I would probably refer to behavioral clinic for this. Okay, so going back, our mnemonic is 3 because we have a regular insomnia insipidus symptoms, but just remember. And the other main reason irregular sleep-wake rhythm is not just 2 sleep periods, because everybody who took a nap would qualify at least 3. Okay, so you can just see that it's all kind of like this. It's really a loss of your circadian. Can be seen in dementia, developmental disorders, some suggestion that the amplitude of those circadian markers we talked about, the core body temperature, etc., just might be diminished. But overall, on those 3 periods, they should have a normal still 24 hours. Okay. So a lot of this can be sort of organization. So, that are they, especially if you have someone with dementia, are they getting enough sleep during the day? Are you doing things where they can stay awake so that their homeostatic sleep drive can actually increase? Are you making things dark at the night so that we get a good signal that this is a sleep time? And you can try melatonin. The evidence isn't robust for it, but you can try to do that to see if it kind of can lock things in. So the non-24 hours, somebody had one? Yeah. So this is a cool disorder. And it used to be called free running, which I think is such a better name for it. But basically where somebody has a progressive delay in their sleep. It's usually about 45 minutes to an hour and a half. And what can happen is over, whatever period of time, they can literally go all the way around the clock. So. Yeah, you can see here. That. You know, we have typically considered this to happen in non-sighted people. So again, that retinal hypothalamic, but there's like an increasing case, series, individual case reports, our own clinical experience that this is happening in sighted people. There's a couple of ones of sort of even people that almost were behaviorally not making themselves sighted because they were either around light all the time because they're in the basement gaming and not seeing any natural light. Or there's just other factors that, you know, that we don't know, but there's definitely, we're having more awareness in people who are sighted. Like I had a college student, 2 weeks ago who was presenting with this. I have no idea why for him. So we do have Petlios, which is a treatment for it. It works on, melatonin 1 and 2 receptors. Normally incredibly expensive. I don't know what and it is actually indicated, unfortunately, for non-sighted patients. Like I have one patient who has just a teeny bit of light perception, but I was not able to get this medication for it. And so here's just the one of the studies of using it to kind of basically lock in the circadian scale. So here's where they were before, starting the medication, and then some stabilization. I've had maybe 3 or 4 patients on it. It's because there's not a big population for it, right? With moderate success. I don't remember when the date I put this, but within the last probably 2 years, I checked it. I know, isn't that not just? I mean, that just. Yeah, maybe somebody should pull and see, like, I don't. Maybe it's gone down, but I don't know if I actually checked that. Okay, no. So again, when you're thinking SCN, have that clue, or not SCN. SCN is a master clock. Sleep-wake rhythm, endocrine functions, alertness, not so much the total sleep duration, okay? We have our Zeitgebers, and circadian rhythms are primarily going to present with both insomnia and hypersomnia, depending on where in that 24-hour day they're having symptoms. What did you guys come up with?
Still expensive, thousands of dollars.
Yeah.
18,000 with good RX.
Yeah.
With
gold,
good
with
RX.
gold membership.
Gold good RX.
That's 1 month.
Yeah.
Without it, it's
Smokes.
probably worth the membership.
Oh, we have a weird world. Okay, so just some questions here. What happens if the suprachiasmatic nucleus is damaged? You guys need the answers.
Yeah, so.
You're very brilliant. Good job. Okay. 53-year-old woman has adequately treated obstructive sleep apnea. She is regularly still feeling sleepy and often falls asleep at 8 while watching television and wakes up between 3 to 4 a.m. What to do?
3.
Very good. Yep, because she has. That's a good face to start. No, I have no idea what that was. Okay. So this is just briefly, you guys can talk about when, for jet lag. When.
It's difficult.
You guys not gone to California
Yeah.
and life is so much easier and then you come back here and it feels bad. Okay. Yeah, okay, that was actually the end, we're done. The question was, and than anyone has. Um,
You're.
Okay, thank you guys.
Thank you.
You have 5 new mnemonics to add. RS, what is RS?
Ralph.
Ralph, quickly,
Yes, right.
serotonin, sorry.
Yes, serotonin.
Serotonin. What's excitatory?
Glutamate.
And what's the